And together, we will move mountains. And if they don't hear our message, then we'll just do it over and over and over and over 1,000 times again for you. And I'll rise up, I'll rise like the day, I'll rise up in spite of you. I will rise, we will rise, we will rise, we will rise.
Hi, everyone. My name is Michelle Zabel, and I'm an Assistant Dean at the University of Maryland School of Social Work and Director at the Institute for Innovation and Implementation. As you all know, this year of working virtually has necessitated some really creative approaches to conferences. We've spread the training institutes out over the last 9 months, just a few workshops each month. And I just want to personally thank you for joining in these discussions. These workshops have been so much richer because of you sharing your experiences and ideas to meet the needs of children, youth, young adults, and their families. So today, I have the exciting opportunity to remind you of some general housekeeping items. Even in a virtual world, they don't let me out of this part. Our workshops are being recorded, and your participation does imply consent. Also, please remember, if at any time you need help in navigating through the virtual spaces or accessing the links to workshops, we have a live help desk chat that is being monitored during the duration of the entire workshop. Our team is posting the link to connect with the live help desk in the chat box now. During all the workshops being offered throughout this series, I really want to encourage you to actively participate by using the chat to post your questions, any comments, and any resources you want to share with your colleagues. Our presenters absolutely want to hear from you, and we know your participation makes the workshops even better. We have staff monitoring the chat in Zoom and on YouTube, and they'll be assisting with facilitating the questions to the presenters and making sure that the presenters' resources are shared with you. So finally, there'll be an ASL interpreter available throughout the workshops. Interpreters will be shown on your screen, and they can be pinned for those who require interpretation. So you want to hover over the video and select the 3 dots. One of the options that appears is pin video. So by selecting that pin video, this video will now not move out of view. This summer, we are continuing the training institutes in a way that will allow you to take us wherever you go. So hopefully you're getting to take a break, a vacation, and get some relaxation. We're recording our summer workshops and releasing them each month so you can watch them anytime during the month that actually works for you. These workshops are on a wide range of topics, all focused on strengthening your skills as you support youth and families. While you're enjoying these summer workshops, we're going to be planning and working towards future training institutes, and hopefully we can all see each other in person. Thank you so much. Take care and enjoy your summer.
Hi, everyone. Thank you for joining us today. We're all here to talk about implementing high quality infant early childhood mental health consultation. Okay. There we go, sorry. Our presenters today include Walter Gilliam from Yale University, Brandy Fox from the Pennsylvania Keys program in Pennsylvania, Lana Schuyler Nenide, the Executive Director for the Wisconsin Alliance for Infant Mental Health, Lauren Rabinowitz from the Center of Excellence in Infant and Early Childhood Mental Health, and myself, who I am lucky enough to work here at the Institute. Our first presenter today will be Walter. He's going to give us just an overview of the importance of infant and early childhood mental health consultation and why we should access and expand this really important service. Brandy will talk about her program in Pennsylvania. Lana will talk about her program in Wisconsin. I'll go over the statewide program in Maryland, and Lauren's going to talk about the Center of Excellence, and we'll end up with questions. So please continue to enter your questions in the chat feature so we can have a robust conversation at the end. And I will turn it over to Walter.
Thank you, Dr. Candelaria. So greetings, everybody. I'm going to talk a little bit about some of the reasons behind early childhood mental health consultation and why we need it so desperately, not only before the pandemic, but especially now coming out of this pandemic. So I've been studying children, in particular, being expelled from preschool programs for quite some time. And when you think about expulsion from a preschool program, that's really the worst case scenario. And when you think about just the rates of it, it's really quite astonishing. Next, you can see that the rate at which children are expelled from pre-K programs is about 3 times that of grades K through 12 combined. When you're talking about childcare, it's way higher than that, about 13 times that of grades K through 12 combined. There was a study that was done that was a little different than what we did back in 2005. In 2005, we were surveying teachers. That's where these data came from. But then there was a survey that was conducted in 2016 of parents as part of the National Children's Health Survey. And when they surveyed those parents, it was clear that the rates of expulsion as reported by parents were even higher than what we had heard previously from teachers. Next, you could take every single child that's expelled from a child care program or a preschool program and fill up every single seat in MetLife Stadium and Yankee Stadium and Citi Field combined, and you still wouldn't have enough seats to hold all of the preschoolers we expel every single year in the United States. You still have about 13,000 preschoolers standing in the parking lot. That's how many children we expel every single year. And again, that's before the pandemic. And if there's anything that we had learned from some of the studies that we had done was this. There's a lot of things that predict the likelihood of a child being expelled. And part of that are things like teacher stress, teacher depression. Teachers who screen positive for depression expel at literally twice the rate of teachers who screen negative for depression. And so what we have coming out of this pandemic is really this, I don't want to call it a perfect storm because it's a terrible storm. It is a terrible storm of risk that basically we have stressed out children from stressed out families in stressed out communities going into childcare programs led by teachers literally on their last nerve. And if there's ever anything that's going to spell preschool expulsion, it's that. As a matter of fact, I'm on listservs right now, and just a few days ago, I got a comment from an early childhood educator on a public listserv asking her peers, what are the policies in her state regarding how to kick a child out of her childcare program? It's literally already starting. Next slide. If you were to sort of graph this in different kinds of ways and compare this to, like, say, something like adult incarceration, you can see on the left the rate at which we expel children per 1,000 enrolled. The farthest left graph is from teacher report from our studies. And then next to that is parent report, about 7.5 expulsions per 1,000 enrolled. What is the adult incarceration rate? Well, next, about the same. We expel from society into jails and prisons about the same rate that we expel from K through 12. But where it really gets interesting is in the next slide. So take a look at here at the gender disparity across 3 different ways of looking at it. Teacher report, report from school superintendents, report from parents. We expel boys at about 4-ish times the rate of which we expel girls. What is the rate of adult incarceration of men over women? Next. About the same, maybe a little bit more. Next, let's take a look at race. We expel from preschool programs Black children at about 2 to 3.5 times the rate at which we expel white children. What is the racial disproportionality in adult incarceration? Next, about the same. And so when you think about it, I guess this doesn't really prove a preschool to prison pipeline, but next, if there is a preschool to prison pipeline, it's amazing how consistent the diameter of the pipe is, all the way from preschool to adult incarceration. Exact same children that we're expelling from preschool programs become the exact same adults that we're going to be far more likely to incarcerate. And it's not necessarily because of the challenging behaviors. We've already shown through the eye tracking studies that we've done and other things like that, that in many cases, we're simply just looking for more challenging behaviors out of boys and out of Black children, and especially Black boys. And one thing that we've learned is this: if you're looking for challenging behavior here, That's where you're going to see it. You're not going to see it over there because you're not looking over there. And so if we can find ways to be able to provide mental health consultation or other types of interventions that allow people to be able to come into early care and education classrooms, not only may it be able to be a way to provide the necessary mental health supports, but it might also be a way to be able to provide a second set of eyes to be able to pick up on any kind of biases that may be in place. Next. Think about this one too. There was a study that was done not too long ago looking at adverse childhood experiences. And when it was looking at these adverse childhood experiences that children were experiencing, one of the findings that they found was that children whose parents were incarcerated were at about a 3 times greater risk of being expelled from preschool. Now, I already told you before that our boys are more likely to be expelled. Our Black children, especially our Black boys, are more likely to be expelled from preschool programs. And we also know from other studies that when you're expelled from an early grade, you're at about a 10 times increased likelihood of being expelled again later on in your educational experience and dropping out of school, placing you at an even greater increased likelihood of being incarcerated as an adult. And so when you put all of that together, next, take a look at a baby who's born. Next, who might be at an increased likelihood of being kicked out of, expelled from a childcare or preschool program. Next, increasing the likelihood that that child is going to be expelled again or drop out of school about 10-fold. Next, which then increases the likelihood that that child is going to be incarcerated. And when that child is incarcerated, and that child has a child of his or her own, next, the cycle just repeats itself over and over and over again. And that's essentially what we're up against. When we're talking about the preschool to prison pipeline, I want you to think about it this way. It's not really a pipe. It's more like a corkscrew. It goes around and around and around. And we can either try to break that cycle with adults, or we can try to break that cycle with children. And I say we do both. Next. Fortunately, in just the past few years, we were able to weave in some language into the Child Care Development Block Grant, and we were able to get some policies passed that increased the amount of attention that states were paying to this issue. 26 states in just the past 5 years that never really had early childhood mental health consultation systems before, 26 states now are investing significantly in it through a variety of different mechanisms. 15 states that did not have bans before now ban preschool expulsion and suspension. In some of the cases, that means every child care program in their state that's receiving public dollars. In some cases, it just might mean the pre-K programs in the public school. So it looks different from state to state, but when you add it all together, it's about 1.6 million preschoolers protected. But there's a whole lot more of them out there that need to be able to get the supports necessary, and their teachers get those supports necessary so that we don't have to rely on something as severe as literally kicking a child out of school before they even get to school. Next, fortunately, we have a couple of statewide random control trials that we've conducted. First one was in Connecticut, where we showed that in just as little as 3 months, a significant decrease in the challenging behaviors that are experienced by children who are likely to be expelled. But better yet, is the study that we did in Ohio just recently, just came out. It was a study where we were looking at early childhood mental health consultation infused into child care programs using a measure that we call the child as a way to be able to focus the consultant not only just on the individual child, but on improving the overall climate and system. And what we found was this: in randomly assigned groups, some groups got the early childhood mental health consultation system that was focused on the whole climate. Some of them didn't. They were placed in a waitlist group. Not only did we find significant improvements in the challenging behaviors that lead to expulsions among the children who prompted the intervention, but get this, we also found significant improvements in the random peers that just happened to be sitting next to that child. And that's exactly what we're looking for, because my dear friends, we will never have enough mental health professionals to help every child in America who needs it, one child at a time. We have to have models that allow us to be able to come in because of a concern about one child, but leave behind residual benefits for all of the children and for that teacher too. And especially right now, coming out of a pandemic like this. And so it is my clear delight to be able to, one, next say thank you, but also to be able to say, I'm going to hand it over to a few states who are doing some spectacular work in this area. Hope you enjoy hearing from them.
Brandy, you're muted.
Sorry about that, missed my cue. Good afternoon, everyone. My name is Brandy Fox. I am from Pennsylvania, and I am the director of our statewide infant early childhood mental health consultation project. And I just wanted to share a few kind of key pieces of our project and maybe spark some ideas and innovation on your part as you return to your communities and states thinking about mental health consultation. Next, please. So we really, in February of 2006, the Build Infant Toddler Task Force issued a report with recommendations in several focus areas, and one of which was to improve the social emotional outcomes for young children. In Pennsylvania, through state level leadership, coordinated communication strategies, and ensuring infants and young children and their families had access to prevention and intervention services to improve developmental outcomes. And Pennsylvania's response to these recommendations was to develop the Early Childhood Mental Health Consultation Program, which began as a grant-funded pilot in 2006, focusing on infants and toddlers. But since 2006, the project has evolved into a statewide program funded by the Office of Child Development and Early Learning, primarily with the task of addressing social emotional needs of young children, birth to 5, and reducing expulsion suspension practices across the Commonwealth. Next. Historically, the program was implemented through 5 regional contracts with state oversight. But in 2019, after some changes within the early childhood system, all of our consultants were pulled under one employer, the Pennsylvania Key, where I work, which resulted in an expansion of the number of staff we had. It created a single point of referral, and our hiring practices actually changed so that we could target areas of the Commonwealth where we didn't have enough coverage. The images here illustrate the program leadership structure, as well as a breakdown of staff educational background. Having a team with diverse professional backgrounds, including both mental health and early childhood education, has created an alternative pathway for those that are strong in both fields to form Pennsylvania's mental health consultant workforce under OCDEL. Next slide. Just to give you a snapshot, many of us might talk about funding, but I wanted to let you know that primarily our funding comes from the Child Care Development Block Grant, with a little bit of IDEA Part C dollars, and also some state funds that are connected to our state-funded pre-K. Next slide. The overarching goals of our consultation approach are to reduce expulsion suspension practices, build the capacity of early childhood educators in supporting the social emotional development of children in their care, and help programs and families navigate to other services and supports in their community. Next, please. There we go. Our program is a child-specific consultation model, which addresses the social emotional development of young children within their child care program. Services are provided at the request of the director or teacher and with the permission of the child's parent or guardian. In Pennsylvania, our consultation services are available to our STARS programs, which are participating in our tiered quality rating improvement system. And that includes childcare, center, group, or family. Also our pre-K count sites, which is our state-funded pre-K. And just of note, we do not serve Head Start, Early Head Start, or Migrant Head Start because we are funded by the Child Care Development Block Grant. Next slide. So our program is really grounded in the public health approach of the pyramid model for promoting social emotional competence of young children. The pyramid model was developed by applied researchers who used scientifically anchored practices to create a functional and adaptable framework to assist early care and education programs, teachers, and families to enhance social emotional development of young children and prepare them for the next, prepare them for their lifelong trajectory. So our consultants work directly with child's teachers and parents to increase their capacity to support their children, and also link and bridge those programs and families to other services should they be needed. Next slide. But we also are really intentional about tying pyramid model practices and mental health consultation to the theoretical foundations and values that guide an understanding of what infants, toddlers, and young children need. For example, how are we teaching childcare educators and parents about attachment and the importance of attachment theory and safety, that babies exist in the context of their caregiving relationships and within their culture, and how do we adjust how we support those children to match those needs? And also, we touch on, making sure that our consultation services are trauma informed, that we're helping childcare educators and families understand child development trajectories and use reflective practice and strength-based approaches to support children in those environments. Next slide. Just a few kind of key pieces of outcomes that we collect kind of at the time of request, pre and post, so post consultation, just so that we can start to continue, I guess, to demonstrate the effectiveness of this service so that the state will continue to sustain, even increase our funding. And so that's, I would say, is one of the strengths of the Pennsylvania model, is that we do have a robust evaluation process. Next slide, please. So the next 4 slides really are just to give you a snapshot of some outcomes that you could achieve through mental health consultation. So our program shows that we have a reduction in the teacher-reported child behavioral concerns. Next slide. A reduction in teacher stress level related to their scope of work. Next slide. That we show an increase in pyramid model practices within that early learning environment, both for preschool, which is this slide, and the next slide, which is the infant toddler classrooms. So you see that mental health consultation can improve a myriad of outcomes within a early learning program, a classroom, or just with a single child. Next slide. So this is a map of Pennsylvania from 2016 that illustrates all the licensed childcare programs in Pennsylvania, which are in blue. And the programs that are our program, our mental health consultation services were able to serve, are in orange. And for many years, the demand for our services was greater than the supply of the consultants and resulted in about a 90 to 100 program wait list per month, waiting for a consultant to be assigned. So all of this evaluation data can start to help a program think about how to revision it, enhance it, grow it, make modifications. So the next slide just illustrates, some of our recent CQI efforts. So prior to the pandemic, as referenced earlier, our team was expanded from about 16 full-time equivalents to 26, and we had hoped to reach nearly double our reach is what we were looking for, and then the pandemic hit. We began collecting preschool expulsion risk measure data to help us triage our waiting list. So that's a really cool tool that can help you kind of assign consultants in the field. And almost all of our consultants have now been trained in the child, which Walter referenced before, the climate of healthy interactions for learning and development. And we hope to pilot this tool over the course of the next program year. Next slide. And many of you have probably pivoted in the last 15 months in response to the global pandemic. And we had to do that too, because we had childcares that were closing, that were no longer in operation. But we had a lot of families and a lot of kids out there that still needed support. So we reached over 750 individuals that were program directors, teachers, and families in a holding space idea, which is just creating opportunity for them to express their feelings, connect with others who were feeling the same way, and provide supports kind of in a broad reach, broad stroke supports for the field. We did switch to teleconsultation, which was quite a heavy lift in terms of trying to support programs who were used to having someone in their classroom supporting them directly to using videos. So we've adjusted and pivoted to the best of our ability. We participated in Health and Safety Regional Task Force, which were groups that were supporting childcare programs in adhering to CDC and our Department of Human Services and Health's guidance, as well as supporting kids and supporting staff wellness, because they were having a trauma response too. And we've done over 400 hours of outreach. So we really tried to broaden our reach, even though we couldn't be out in the field. And the next slide. And so what's next for us really is revisioning, using that data about our pandemic has really made us revision kind of what our hopefully our tiered consultation model will look like. So next, we're going to look at universal consultation. So continue those holding spaces, office hours, a public awareness campaign, and some professional development. I know I'm running out of time. We're going to create a kind of more of a universal tier of consultation that is directed at the program or classroom. So before they identify a single child that they need support with, how can we get into those star ones and star twos and build their capacity and their workforce's ability to embed really good practices in their routines during the day to prevent the need for a single child to rise to the top of the pyramid. And we'll continue our child-specific consultation next, which is really that focused on that child. You can, all right, and the next slide, which I think is my last slide. And really just to give you a sense, public awareness is a huge piece that our state has invested in. And so oftentimes we were word of mouth referrals, and we're still to this day after 16, 15 years of being in place, there are programs that don't know we exist. So we're doing a public awareness campaign. We've updated our brochure. The link is in the slides. But we have to recognize that when you increase your promotion and when something is really new, you may find that the demand is bigger than the supply, and that the wait list might make your staff have a lot of anxiety. So we will be managing that, but it is all carts ahead on this one. We're just trying to expand and try to meet as many program and families' needs as we can. So thank you very much. And I am passing it on to Lana.
Thank you, Brandy. My name is Lana, and I work for Wisconsin Babies at the Wisconsin Alliance for Infant Mental Health. And we're a statewide nonprofit charged with supporting social and emotional well-being of infants and toddlers in the context of their most important relationships. And my story will highlight what we have going in our state as it relates to consultation, and also what could be, because we are in a very exciting time in Wisconsin. The time of the biennial budget is about to be approved, hopefully by July 1st. So, but before we get there, let me set the context a little bit for you. Next slide, please. So in Wisconsin, at this time, we do not have a very well organized, robust way of capturing and tracking suspension and expulsion data. So the chart you're seeing is our most recent data. That's the data collected by our Department of Public Instruction and analyzed by that department. And so what you're seeing is the rate of suspension of children from public 4K and beyond. And so not only you're seeing that very young children, our 4-year-olds, are suspended at astoundingly high rates, you're also seeing that Black children are suspended at significantly higher rates than children of any other race. So as you can imagine, and as you can see, this is absolutely awful and shocking. On the other side of the slide, you're seeing data from the childcare providers. So the chart is from our school system. Our 4K is our universal preschool, 4K for 4-year-olds. And on the other side of the slide, you're seeing data from our childcare providers. And so, and this is data from 2017. This is our last attempt on capturing what we have in the early care and education system. And to probably no surprise of yours, challenging behaviors are #1 reason that children are being expelled. Boys are expelled at higher rates than girls, and Black children, again, are expelled at higher rates than children in any other race. So, as you can see, we have a huge problem. Next slide, please. And then you add pandemic to this, right? You add pandemic to the mix. And we have to acknowledge that infant and early childhood mental health, social emotional well-being of very young children is very very tightly connected to the well-being of adults in their lives. And the truth is, adults are not doing very well at all. So this is just some of the news, our local news. La Crosse County is the county in the western part of our state. Drug overdose, death nearly double, drug and alcohol overdose, opioid crisis. So adults are not doing well. So children are not doing well. A dear friend of mine who is a child psychiatrist who specializes in working with very young children sat down with me, and she said that I have never in my whole professional life have seen so many sick kids. And of course, she meant the mental health of the children. She's never seen so many children who are depressed and anxious and suicidal. And so, again, as Walter was pointing out, if we ever needed solutions and supports, now is truly the time. Now is the time. So there is a great need, there is great urgency, and so we need a thoughtful, solid solution. Next slide, please. And so just like in many other states, Wisconsin has Governor's Early Advisory Council. It's a council of advisory members who are appointed by the governor and represent many systems and disciplines that are related to the early childhood. I am one of such members. The council is co-chaired by the state superintendent and by the secretary of the Department of Children and Families. And the council's job is really advise the governor on key early childhood issues and come up with recommendations. And usually these recommendations have budgetary implications. And so the recommendations are aligned with the cycle, the budget cycle. And so these were the recommendations that were proposed to the governor at the end of last calendar year. And again, our budget year begins on July 1st. So these are the recommendations, and I want to walk you through these recommendations. This is an achievement in and out of itself. It's not enough. Of course, it's not enough, but it feels like a bit of a victory to have social and emotional health recognized. And finally, for the first time ever in my state, to establish a system for consultation, and then to expand our current pilot of Behavior Health Wisconsin. So let me tell you a little bit about social and emotional development training and coaching. So next slide, please. One of the signature programs that we have been implementing for a number of years, since 2010 actually, is the pyramid model. The same pyramid model that Brandy was telling you about. We call it Wisconsin pyramid model, so it feels closer to home. A pyramid model is a culturally responsive and equitable multi-level system of support designed to improve social and emotional competence of very young children. It's a very effective framework. It has a very significant training component. It's not a training in and out of itself, but it has a significant training component. And you can see that for a long time, we have trained over 11,000 people in about 14 different strands of the training. So that's important. What we have been really promoting and what we are really proud in our state is what we call program-wide implementation. That is implementation with fidelity. We have programs apply for this implementation because we know that they need to be ready. They need to be ready, and by that we mean that they need to have commitment. They need to have their administrators, their leadership on board. They need to have program leadership teams. They need to understand that they will be collecting data, and not just collecting data, but using that data to make sense of what's happening, to support their teachers, and to really commit to supporting social and emotional health. So there's just some data for you. We just wrapped up launching of the cohort 15 that we had to do virtually, but we have 15 cohorts in the state of Wisconsin. We have measured teacher practices using TPAT for teachers who work with preschool age children and TPTOS for teachers who work with infants and toddlers. And it's really exciting also that, and these sites are all over our state of Wisconsin. And it's very exciting and really important that we have state infrastructure, state buy-in and state leadership around the implementation. So we have state leadership team, and the team has met really regularly for over about 12 years. And for the past, my agency has been always involved with coordination of the pyramid model and has been really working to support and lead the state leadership team. So these two state coordinators have been consistent presence for all of the years we've been working on this framework. Recently, we have split our leadership team into two teams. We felt that it's important to have a team of worker bees and then a team of advisors, like secretaries of state departments and executive directors and administrators. And so the advisory team is larger, and it meets only twice a year to really share wisdom, advise, and sort of bless what we're doing, which is very important. And the state leadership team has been doing annual assessment of state implementation. So we are guided by benchmarks of quality. It as a consistent tool comparable to what programs are doing on their sites. So this is exciting. And we have this parallel structure for what's happening on the program level and what's happening on the state level. Pyramid model works. And if I have only one slide where I can show some more data, that's the slide that I would like to share. So Margot, if we could go to the next slide. This is the slide that shows you that children who live in programs that implement pyramid model, that's the blue line, over time from winter to spring, have a significant reduction in challenging behavior, as opposed to children whose teachers have been introduced to the pyramid model through training, but who do not live and practice in programs that implement pyramid model. So again, for most vulnerable students, challenging behaviors decrease significantly if they land in programs that implement pyramid model with fidelity. And again, if we remember that challenging behaviors seem to be the #1 issue, we can say that it's very effective in maintaining children in having their needs met and boosting their social and emotional competence. So that's the pyramid model approach. And we have been, again, really successful in implementing the pyramid model. Next, we had an opportunity about 2 years ago to bring this program, Behavior Help Wisconsin. It's a new program. It's a tiered approach to infant and early childhood mental health consultation. And we learned about this program from our colleagues in Arkansas. So we're deeply grateful for their expertise. We are at very early stages of this program. And again, it's a tiered approach, and this approach is only relevant to the early care and education setting. So if we go to the next slide, it's a 5-year pilot program. This is funded by our School of Medicine and Public Health at the University of Wisconsin-Madison. We are piloting it in 4 counties, very intentionally, 3 rural communities in Wisconsin and 1 deeply urban community in Milwaukee. We have child care resource and referral programs, university evaluators, quality coaches, and infant mental health consultants involved in this program. Everybody who does work in the program has been trained and reliable in Walter Gilliam's child tool. So there is some consistency between what states are doing, which is super exciting, I think. The way this works is it's a bit of a reactive, kind of the urgent care room approach. So when a teacher or program has a child that is very puzzling to them, a child who is at risk for being expelled, they reach out to their resource and referral program. And it's very intentional because that's the program with whom they already have relationship. And then a quality coach is sent to the program in good old times. Now, during pandemic, we did this via technology, which is not ideal, but it's possible. We learn so much. We're very adaptable, highly resilient. Quality coach does the observation. And in most cases, in about 65% of the time, quality coach can successfully support the program and the child care provider. In about 30% of the time, quality coach realizes that they sort of reached the limit of their ability and consultant is called. And usually it happens if the child is involved in multiple systems, if there is a mental health issue, And then the consultant works with the programs. Next slide, please. The set point is that our first year of implementation was 2020 when the pandemic hit. And so I highly do not recommend trying a new program during global pandemic. It's just a really not a good idea at all. So we were put on hold. We were trying to switch really quickly into providing everything via Zoom. We have not a huge enrollment, possibly because some of the programs were simply just closing. And so we hit a hiccup. And so we are pivoting and will be continuing implementation of this program and hoping for more enrollment, better data, and more evidence that it is effective. And in the meantime, when all of this is happening, next slide, please, we've kept dreaming and thinking and planning about what we really would like to implement in our state. And so what we really would love to do is implement and bring this universal approach. And so the idea is that we want the no wrong door approach. We want a universal model of consultation because we acknowledge that our children do not only live in one system, and no one system can resolve all of the issues. So what we want in Wisconsin, we want a consultation that really supports and serves all systems and discipline, child welfare, and early care and education, and Part C, birth to 3, and home visitation, and even pediatric field. We really want a consultation that cuts across all systems and discipline, which really underlies, in our opinion, infant and early childhood mental health. And as we were dreaming and thinking and planning, we realized that we really need a workforce that is qualified and culturally responsive and diverse, because consultation by nature is a highly deeply relational approach, and it will be as good as the people who provide it. And so we decided that we needed to figure out what are the competencies, capacities, and what is a pathway for somebody to become a consultant. So next slide, please. We decided that there were some non-negotiables, such as we want our consultants to hold master's degree, and we want them to be licensed mental health clinically trained professionals. And we developed a pathway for them. We decided that there are certain knowledge and expertise they should have, but then we will onboard and orient them to our model. We will provide them with additional training, and we will build on existing things we have in our system. So in Wisconsin, much like in other states, much like in Pennsylvania, we have infant mental health endorsement, a competency-based verification system that will help us know who and verify who has in fact relationally based culturally responsive practices. We also have infant mental health capstone program through our University of Wisconsin Department of Psychiatry. So we have already ways to build and expand cadre of consultants to work in our dream model. And so as we've been doing that, we had to acknowledge and come to grips with the fact that while social and emotional training and coaching is in fact addressed in governor's budget. So this is very exciting, and we hope very much that our legislature keeps it in the budget, please, pretty please. But consultation did not make it in the budget. But we are not the kind of people who give up. So next slide, please. We've partnered and we've developed materials, and we've developed really strong collaboration. And we're right now in the midst of very significant advocacy campaign that lets legislators know that we're really serious about this, that this is not the time when we could just ignore the fact that we have a lot of babies and toddlers who have been exposed to significant trauma. And so I just want to quickly highlight really exciting partnership that we've developed. The particular partnership with Wisconsin Professional Development System and Wisconsin chapter of the American Academy of Pediatrics. Our pediatricians had their advocacy day at which they knocked on, well, virtual Zoom doors of legislators asking for infant mental health consultation. I think that's very impactful and it's very powerful. And it really showcases the whole idea of comprehensive, holistic approach to health. So it's really exciting. Next slide, please. So we have the budget that we've developed. You see now the map of Wisconsin. We have 5 regions, and these are regions that are developed and used by our state departments. So again, we're proposing a regional approach. We have our broad budget categories. We're asking, and our ask is consistent with the ask and recommendation proposed by the governor's Early Childhood Advisory Council. We're asking for $5.3 million. And we are very much hopeful, and this is, you know, a developing story. Really, truly, it's within the next couple of weeks that we should know. So very, very exciting times. Next slide, please. Again, with the resources that were provided by the Wisconsin chapter of the American Academy of Pediatrics, we developed a lot of tools and communication kit and digital media kit that we've been sharing with our members. Again, all of the organizations have been sharing with their members, and we are working hard to really ensure that this gets visibility and this gets some level of funding. So we are very, very hopeful. And again, it's a developing story. It's a story of persistence and perseverance, and that's a story of hope. So let's see what's going to happen. But in terms of next steps for us, so if I could get to my next slide, we will continue implementation of the pyramid model. We will do what works. We will do what's practical. And we know that implementing universal practices is highly effective. And for 80% of the children, sufficient. So we will continue to do so. We will provide our tiered support and infant mental health consultation in the 4 counties using the Behavior Health Wisconsin approach. We will continue to advocate. Now is not the time to give up. And we are very hopeful that the legislators will hear us, and we will work to diversify and expand pool of consultants and to secure funding to make our dream of universal consultation come true. And hopefully it will be there. Maybe next time we get together, I get to show some data about it. So thank you so much.
Thank you, Lana and Brandy. Those are big, shoes to follow in terms of state models. You guys are doing very, very good work. So I am with the University of Maryland at the School of Social Work at the Institute for Innovation Implementation. I'm going to go over our model here in Maryland. In full transparency, this is through a partnership with the University of Maryland and the Maryland State Department of Education. It started in 2006 as a venture between the University of Maryland, the Behavioral Health Administration for Maryland, and the State Department of Education and Georgetown. And they piloted it in 2 jurisdictions, had really good findings, and were able to write it into the state legislature through the Child Care Development Block Grant. And since that time, the Institute has been supporting workforce development, implementation, and evaluation. And so I actually oversee all of our evaluation efforts. I also used to be a consultant way back in my baby professional days. This is just a visual of our state. We have 24 jurisdictions that are covered through 11 programs. So some of the larger jurisdictions or more populated jurisdictions, they only have 1 program, but some programs have multiple jurisdictions, as you can see. We have 38 consultants. We have a fairly mixed workforce, so only 18 are licensed, but they're all master's level. Last year, we hit 382 children that received child level consultation and 64 classrooms. You can see down at the bottom, this was lower, obviously, because of COVID. We typically, and that actually only shows part of the COVID. It was part year non-COVID and then COVID. Typically we hit around between 550 and 600. But we are really pushing to not be so child focused and really focus on that sort of classroom level, program level support to have fewer kids that have high level needs. The average case is seen for approximately 4 months, but again, it varies. And we did spend the last 2 years in developing, and then this year, of course, as Lana said, it's hard to start something in COVID, but the plan was in July to launch these new state standards and really upgrade our program and how it's being implemented. And that has been, challenging when childcare was shut down and COVID interrupted a lot of things. So like I said, we are primarily funded through the state, through the Child Care Block Grant, but there are several programs that independently have supplemental funding. So that may come from a county grant, that may come from a research grant. One of the jurisdictions was covered through a SAMHSA system of care grant that allowed them to expand their sort of higher end clinical services. So it does look different jurisdictionally or by program in our state. One of the things we did when we upgraded the standards was to really take a look at our workforce. Nationally, the recommendations are, it's preferable to have clinically licensed folks, although there isn't a ton of data yet on that. We wanted to see who we had and what our outcomes were before we made any changes or requirements for changes. So what we did was just a natural sort of experiment of what children over a course of 2 years were seen by someone with a licensed, a clinical license versus not, looking at preschool mental health climate scale outcomes. And what we had were, I think, very good findings, which is we see improvements in positive behaviors and reduction in negative behaviors either way, right? So these are consultants that are working hard and, their heart's in the right place and they care about the work and they care about the kids and they're doing good work. And so that's great. But we do see significantly larger findings. So there's a difference, like the positive changes are greater and the negative reductions in negative behaviors are greater when we have a licensed clinician. And what we ended up doing was using those findings to say to the state, let's create this tiered model where we have both licensed and non-licensed, but require every program to have a licensed provider on staff, because the distribution was sort of unequal. Some jurisdictions had all licensed, some people had none. And so we really want to have an intentional tiered approach. I can skip that slide, was just more statistics. So this is what we ended up doing, was just create, you don't have to read this, but just to say the unlicensed providers can do sort of some tier 1 and some all tier 1 and some tier 2, and the licensed providers can jump in at tier 2 and tier 3. Now you can have a licensed provider do all of it, but you certainly don't need to. And we are in the process of working that out with the 11 programs now in terms of what it looks like. We do have a statewide evaluation system. So it's a web-based portal where every consultant enters data into this web-based portal, which we call the OMS, the Outcomes Monitoring System. This is just a snapshot, but if you go down on the left, you'll see all kinds of things where you can enter ASQs, preschool mental health climate scale, DECAs, TPOTS, all kinds of things. They can pull their own reports by program, but we do really deep dives quarterly and annually for each program and for the state. We always provide a brief to the legislation to show the findings. This is just a snapshot of the most recent one that shows that in the past year, we served pretty much predominantly males, pretty even distribution between white and then Black or multiracial. We are seeing mostly kids 3 to 5. One of our goals, because the state has a Pritzker grant to focus on prenatal to 3, was to increase the number of kids served prenatal to 3 within consultation. Of course, it was hard to hit that mark because COVID hit, but we're working on it. But we do typically every year see reduction in teacher and parent reported behavioral concerns, increases in child initiatives, child self-control, increases in classroom climate. So we sort of have ongoing every year evaluation efforts that show the positive impact this has on kids and classrooms. Like I said, we had to make a lot of pivots, as Brandy said, as Lana said, during COVID. And in some ways, it's been good. It's really helped us sit down with programs and rethink some things. It gave us some time to say, what are some other activities we haven't had time to do that we might want to do? And as the evaluator, it gave us like a rethink on what are we capturing and not capturing? Because we realized that like in our OMS system, a lot of things weren't sort of enterable. So we had to open new fields and really capture some of these different kinds of activities. We also started doing more intentional support to the workforce. So we have a monthly, what we call facilitated conversation, where anyone can show up, and we have some general topics that we want to go over. So for example, virtual observation in COVID, or, you know, putting an action plan together in COVID. It was a lot of in COVID topics when we started. And then people bring questions, and then we started office hours for consultants. And then because I think unlike Brandy and Lana, it isn't so much centrally located at the state. It is really locally driven, which is much of Maryland. We started having a leadership sort of directors meeting to make sure what the consultants were hearing was actually consistent with what the directors were hearing. And so I think that's been really helpful. I think I said everything on that. You know, we're using the national pyramid model. I put it in like CEPHL in parentheses because that's the old term, but Maryland is having a hard time fully relinquishing it. We're really trying to engage more intentional practice-based coaching, focusing on the workforce with how do you adopt a consultative stance, increasing our training in reflective practice and reflective supervision, strong engagement in equity and anti-racism work. Partnering with our local resources and local referral networks so that you're not just relying on the consultant, but when there are greater needs for a family, whether it's specific to the child's behavioral concerns, or just some other family concerns, that you understand what else is available to help families. And then an intentional partnership with Part C, infants and toddlers. You guys heard a lot about the pyramid model. We use it. You don't need to hear it again. One of the big things we have really dug into, and I think had time to do during this year, is through partnership with Lawrence Center, we're working with the Indigo Cultural Center and looking at our equity work within consultation. So we started with a 2-day equity retreat, and now we do small month group facilitated, like sort of coaching sessions around sort of self-reflection and your sort of personal self, but also in the work. And then what do you do when you see it happening within the consultation work? And then there's also monthly leadership meetings that are focused on that. And then we've pulled that into our facilitated conversation, our office hours, and our leadership meetings. You know, we have traditionally been within childcare, as Brandy said, because it's funded through the childcare block grant. This is separate from any consultation that happens in Head Start or other settings. But in an effort to really address young children, 0 to 3, we really wanted to partner with infants and toddlers who may or may not be in a formal childcare setting, but may also have behavioral health concerns. And we also, through a separate funding source, have a partnership with that division of the State Department, with IDEA folks. And so we were able to sort of say, hey, like, who in your county would you like to, who in your, some programs have multiple jurisdictions. So we said, pick a county you think you could work with. You already have an existing relationship, and we're piloting it in 3 counties now. And then the intention is to figure out the cost of it and then determine it statewide, or expand it statewide. One exciting thing that happened this year is there actually is a legislator that cares a lot about early childhood, and he actually wanted to ask for more funding, but he realized that in this year it would be hard to just straight up get more money, and so he thought it would be helpful to propose a study. And so we testified on behalf of the benefits of infant and early childhood mental health. We got a parents testified, program providers testified around why this is a great program. And then we were also able to show the data on how we don't have enough. We can't pay enough people to really meet the needs throughout the state. So as an example, there's 2 early childhood mental health consultants for all of Baltimore City. And there's like 19,000+ childcare slots, right? So that's clearly not enough. So this year, what passed was they're doing a gap analysis study. And so we're collaborating with some other researchers in the state to do a sort of more intensive study about where needs are being met and where they're not, and what it would cost to really expand it and take it, you know, even deeper. You don't have to go into all of this, but just to say that we've spent the last few years making sure that we have really aligned with Maryland's readiness and the path to school readiness and success strategic plan. So we are in alignment with other initiatives going on in the state. And so that early childhood mental health consultation isn't seen as this like weird early childhood thing, but that it's really seen as this part of the 0 to 21 system within the State Department of Education. And we are really looking at how do we expand our workforce. And part of that is also just saying that not every, we're trying to move away from a crisis response model where like when kids are like a significant concern, then they get called when they're about to be kicked out. And we also have seen anecdotally the kids sometimes get kicked out in the time they've made the call, but before the consultant can get in. So we're really trying to move towards this, like, let's use some pyramid model practices to look at classroom level practices and, you know, the bottom of the pyramid stuff. But we still do need more workforce to hit all of those tiers. I think I'm done. I think I'm under time. So next is Lauren, and she's going to talk all about the Center of Excellence.
Thank you so much, Margot. And we didn't plan it this way, but I am super glad to be able to go after Maryland. Because when you said how years ago you were a consultant, so Margot and I actually met many years ago when I was a baby social worker doing consultation work in Baltimore City. So it's always so fun when our paths cross again. So good afternoon, everyone. It is really a pleasure to be part of this panel. I hope you all are as impressed and excited by the work that you're hearing about from these programs. To me, this is the most, it's so exciting to hear how different states are implementing infant and early childhood mental health consultation. Yeah, there's a lot of challenges, but I think you can hear the enthusiasm and the passion, and that's why this work is just continuing to grow and expand across the country in all sorts of settings, and so, yeah, super exciting. So I am lucky enough to be part of the Center of Excellence for Infant and Early Childhood Mental Health Consultation. So we are a SAMHSA-funded center. You may or may not have heard about the Center of Excellence in the past. So this is actually the second iteration of the Center of Excellence. The first one ended in 2019, and that is when this new center began. And we are, well, I'll go to my next slide. So here is our mission and vision. We are not shy, and our goal through this work is to overall impact this growing field by really taking a very close look at it. We want it to be seen as a profession. So we hear all sorts of different words out there to describe mental health consultation. Is it a service? Is it an approach? And without going down the rabbit hole of wordsmithing today, this is really a big part of why there is this federally funded Center of Excellence, is to help provide specificity, support, all sorts of different training resources, technical assistance, research support to grow and advance this profession. I wanted to pull out a bit on equity. So you heard Walter's fantastic introduction just a little while ago today, and I'm so glad we started with his talk, because sometimes we talk about equity and we talk about why we do this work, and I worry sometimes that we kind of forget, and we want to make equity part of the work, and we say the words, but just to remind us all, equity is part of infant and early childhood mental health consultation. It's not just sort of the standalone piece. Like it is the work. It is why we do this work, and our center has a very deep commitment to that. So not just always elevating that point that equity is a central component, but really thinking about how mental health consultation can build capacity, how it can be, I don't know if anyone here has had the opportunity to hear Dr. Eva Marie Shivers talk about how consultation can be a disruptor of bias and how it can support culturally responsive practice. So I just can't let an opportunity go by without being as explicit as possible about that. So that is a big part of our work, and I'll talk about that a little bit more in a moment. Next slide, please. So how are we working on this really lofty goal of advancing the field? So we have captured our work in sort of 3 different main areas of focus. There's, of course, a lot of overlap between these areas, but it is helpful, I think, as we are exploring, as I'm sharing with you what the center is, and hoping that some of you will avail yourself of our resources just to look at these 3 different sections. So the first is programmatic support, and I'm going to go into each of these areas in more detail. So first is programmatic support, second is professional development, and third is this very big idea about creating a mental health consultation clearinghouse. So we have a fantastic team to help us get there. So Georgetown University, we are the leader for the grant, and we partner with a huge number of folks across the country. That is one thing I'm the most proud of about our center is how many people we've been able to pull in. So we work with Tulane University. We work at the Children's Equity Project, which is housed at Arizona State University. We have just a number of folks across the country that are subject matter experts that work with us. And we also have something called a consultation council. And this is a group that's a little bit different than an advisory group. This is actually a group of folks that some do sit within the mental health consultation space, but most actually sit a little bit outside consultation and are in different segments of the early childhood system. And we designed that really, really explicitly to make sure that consultation is that we're paying enough attention to all the other facets of an early childhood system. Some of you might have heard about talking about systems with a little s or a big S, and this is not a presentation on systems in that sense, but I just put that out there to say that it's really important to understand that. You've heard from these different state examples today how incredibly important it is to develop partnerships. And so at our Center of Excellence, to emulate that. And so we have this consultation council. And more information and details on all of our partners can be found on our website. Next slide, please. Okay, so I'm going to talk a little bit about our programmatic support. So when I say programmatic support, it is that. It is providing support directly to mental health consultation programs. And when I say program, we define that as loosely as possible. So it could be a statewide program like Pennsylvania that has been around for years and years and years. It could be a very small pilot, something that was maybe someone wrote about doing consultation in a grant and hasn't even actually started yet. And we would be delighted to work with you. So in the past 2 years and change, we just started our 3rd year. We have been able to work with 57 programs so far at either a state level, local level, tribal level. And if there's any other permutations, I think that's about it. But yeah, so we really try and keep that very, very wide. In terms of the resources that we are developing, we have 5 different areas of focus that you see on your screen. So equity, research and evaluation, program development, financing, sustainability, and workforce. These are clearly not areas that only have to do with programs. They also have to do with professional development, with workforce, etc. But want to, just sometimes we have to pick a place to start talking about it. So I just wanted to put that here. This is, loosely how we group our resources. I do want to highlight the research and evaluation section of our website. There was a fantastic new set of resources that were released about 6 months ago at this point. And if you are, again, in any stage of implementation with mental health consultation, I urge you to take a look at these resources. In particular, 2 documents I think you will find really useful. So one is a theory of change resource. So you've heard a lot in this presentation about why we do mental health consultation and what it looks like in 3 different states. We haven't spent as much time talking about exactly what it is and what it isn't, because there's just only so many minutes and information we could squeeze into this session. But if you have a few minutes, there's actually a lovely video that is on our website that takes you through the theory of change that really says, all right, what are these inputs of mental health consultation? What does it look like when you start? You have these essential elements, and then what do you get at the end? What are actually some of the outcomes? So that is a fantastic resource that was written to be useful for anyone just starting out on their consultation journey, all the way through perhaps bringing to a legislature or someone who's like, what is this? Why would we do it? And the other, and I have lots of things I could flag for you, but I'm just trying to pull out a few to get you really excited about some of our resources, is an evidence synthesis. So our research and evaluation team took the lovely journey of diving through the evidence-based literature to really pull out what is out there on mental health consultation. So they did a lot of that groundwork. It's a hard sift to get through and pull it out, and gave a really nice synthesis of really what is it that we know right now about consultation, and then provided some areas of where should we go next. I think you've heard on this presentation today, we know so much, and there is still so much more that we want to know and understand about consultation, particularly about exactly why it works, right? Like, we know it works. We know some of these really core ingredients, but we're still trying to figure out or get a little bit closer, I think, on some of what makes it such a magical intervention. Next slide, please. So for professional development, when I say this is really resources that are designed for consultants. Because of capacity, we are not, as a center, able to do direct training for consultants in programs. So what we do is we create as many online resources as possible that are accessible to consultation, to consultants, to program leaders, really to anyone. So these are 3 that I have that I'm highlighting here that I think are very, very important. Again, if you were just getting started with consultation, this is always where I send folks to start. So the first is with our enhanced infant and early childhood mental health consultation competencies. These were started probably like 2 decades ago and have gone through several iterations. But this version that we just re-released, we went back through with our equity partners and really elevated the equity language, and I think they're stronger than they've ever been. So I encourage anyone to take a look at those, because at least Lana, and I can't remember if anyone else mentioned endorsements. I just want to put out there, these competencies are completely complementary to any kind of infant mental health endorsement system. They are specific to consultation, but I get that question a lot. They are very complementary. And then from these competencies, we also have 8 foundational modules. So there's 8 competency areas, and we have developed modules for each competency area. And we also have a consultant assessment. And what this assessment allows, it's a self-assessment, it's for consultants. We're actually doing some pretty deep revision of it right now based on some feedback we got. We released it about 8 months ago now. So we are doing a little bit of revamping on the scoring and sort of what the feedback, but it is out there. It is a great tool. I encourage anyone to use it. It helps you really gain a sense of what are your areas of strength and where are areas that you have to go to continue learning. I also want to mention that we have ECHO groups, and right now you'll notice it is actually intentionally spelled that way with only the E being large. You may or may not be familiar with ECHO. So this is I believe that it's referred to as a tele-mentoring model, kind of a guided practice model. And we did a pilot of that this last year, and it's basically online training. We do have a few training opportunities specifically for those in rural and underserved areas. And I'm excited to say that in another month, we're going to be able to change that, those lowercase CHO to all capitalized, because we'll be officially trained and part of the Echo Hub. So look for that coming out as well. Next slide. I think I have just a couple of minutes left. So what I want to mention here is, for all these different things you're hearing me talk about, all these resources we're creating, this is all in service of, at the end of our 5 years, we would like to have our website be the infant and early childhood mental health clearinghouse. So the one place that you need to go to get access to everything. So whether you are a consultant, whether you're managing a program, an advocate, even a consumer, I didn't even mention that. We have a new document that we worked with a family-run organization to actually create something about what does consultation mean to a parent or to a caregiver. So that is really the way that we want to just put this all together and make it as easy as possible for folks to get information. Next slide, please. To do connect with us, this is our website. There are email addresses on here. Mine's in a minute, and you are welcome to email me at any time. I have the link here to request technical assistance to become a member of our virtual community, which is something we are really trying to get the word out about, so you can learn from each other. At the Center of Excellence, we really see ourselves as a hub and trying to make it easier for all the spokes to be connected. So that is all the information there. We are growing our social media presence as much as we possibly can. Next slide. These are links that you heard throughout this presentation. And next slide is everyone's references, and then contact information is on our next slide. I know I speak for everyone. We would love to hear from all of you. And let's go to the next slide. And I'm going to stop talking, and we are going to open it up for questions. And really, thank you all so much for your time.
Thank you. So we have quite a bit of questions in the chat. So I'm going to read off some of the questions that we have, and then I'm going to encourage our presenters to try to answer very quickly so that we can get all of the questions answered. So the first question goes to Walter. Is there any data that shows the impact of infant and early childhood mental health consultation on outcomes other than expulsion and on child serving professionals other than teachers?
Great question. And I didn't know that would come to me verbally, so I went ahead and I answered it in the chat. So so if I can, I'll try to summarize that. Basically, yes, there's quite a bit of data that shows the impact of early childhood mental health consultation at reducing teacher job stress and burnout. A study that was done in Illinois recently using our child tool that showed improvements after early childhood mental health consultation in the equity in which the teacher was displaying in the classroom. Basically, the teacher as a resource. How is that teacher distributing herself equitably across all of the children? Some positive findings regarding, as I'd said before, not only impacts on the children that prompted the mental health consultations request, but also on the other children who are nearby to that child. Some positive impacts on overall social emotional climate, and then also a positive impact that we're very excited about, which is along the lines of teacher self-efficacy and locus of control. Because one of the things that we had found is that when teachers feel out of control of situations, then it's hard to really get much of a positive impact. And the only way that we can actually be able to help teachers feel more able to be a positive force within their classroom is if they feel like they actually have some sense of control over what's happening. And so for us to be able to find that impact, that was meaningful for us in terms of just the general model of how we think about mental health consultation. Oh, also, I should also add that the other thing that we know is this: mental health consultation works better than just about anything else similar to it that you can think of, and it has positive effects across the whole system, and it's also cheaper. It's cheaper than outpatient psychotherapy. It's cheaper than the added cost of special education. It's cheaper than another year in preschool or childcare because the child is deemed not ready for kindergarten. And so when you think about it, not only do you get all these impacts, but you get them kind of across the system so they're sustainable. and it's cheaper, and it has fewer tiers attached to it.
Thank you. The next question I have is, could you talk more about the preschool expulsion risk measure and how to use it? And that question is for Walter also.
Okay, but I'm happy to like share the wealth and other people answer questions too. The preschool expulsion risk measure was a measure that we created simply because we wanted to have a measure for the outcomes of early childhood mental health consultation that didn't require waiting for children to get kicked out of childcare programs. I mean, that's a terrible outcome measure. And so we really needed to have a measure that measured, well, how close is this child to being kicked out of a childcare program? So we created this preschool expulsion risk measure, which does a really good job, unfortunately, at predicting children who the teacher is likely to request a removal from their childcare program. It has 4 factors. All 4 factors seem to be related to teacher decision making. If the teacher sees that the child is creating a disturbance in the classroom, if the teacher sees the child as adding stress to that teacher's life, if the teacher feels that the child might do something like harm another child or harm himself, and the teacher be held responsible for that harm, and if the teacher feels hopeless, that anything could ever possibly happen that would improve the situation. And unfortunately, you know, when children tick all 4 of those boxes, then the likelihood of them being expelled goes up. But please, 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 please do not use this as a measure to decide who to expel, because the answer is no one. This is not a measure used to figure out who to expel. This is a measure used basically to figure out who is most at risk so that we can come in and intervene.
Okay, thank you. The next question is going to go to Margot. In regards to Maryland slides, the demographics show 52% white, 30% Black, and 10% other. Is this due to parent refusal in the races where the numbers are low, or are there concerns of the program being offered to all races equally? And there was some conversation about, Brandy, I know you chimed in the chat about Pennsylvania. So I really wanted to amplify that conversation.
Okay, I can't see the chat at all, but well, there's a couple of things. So one is it's statewide data, it's not regional data. And we have started to look like by program and by region because, you know, there are areas of the state, which is, you know, very common with other states like Baltimore City or jurisdictions that are closer to Washington, D.C. that are primarily people of color or more evenly mixed. And then we have rural districts that are primarily white people. And we did make an effort to look, I don't have it in the slides, actually for our Pritzker grant, we looked at it and it doesn't look exactly the way we thought we wanted it to look, you know, in terms of there are some white counties where only Black kids are getting consultation, and I'm not sure what that means. And there are some areas where you would expect it to look, you know, just to be more reflective of the population, and it just doesn't. So we need to do a deeper dive into that. The other piece is there is one of the things we also have been working on is not having missing data in the OMS, right? So I can only give you data to the extent that the consultants are, you know, putting in data, and sometimes there's just missing data. It's just not in there. So that I hope that more fully answers your question. It is one of the things that we want to look at is as part of our equity work, but also just part of our evaluation work, is to do a better analysis of, you know, really who is getting consultation, and does that make sense?
Just to chime in, I think, you know, from Pennsylvania, you know, we started gathering gender, race, ethnicity, language for children, and we're working to hopefully over time access our professional development registry, so our early childhood workforce registry, and also get gender, race, ethnicity of educators and try to do some comparison of outcomes to really kind of get at that equity and accessibility type lens and improve our program approach.
Brandy, we're having those conversations as well. understanding who the providers are, right? And is there a match between providers and children, or between consultants and the children, or consultants and the teacher? So really it's multi-layered, but we're starting to look at that data too.
Okay, thank you. And we have one more question. Okay, sorry about that. We have one more question. There seems to be an enormous diversity in the models of mental health consultation. What does the research tell us about which models work best? And what are the core components in terms of teaching skills? And this question can go to anyone.
Well, I think Walter has data that the embedded model works best. But I don't know if somebody wants to go over. I mean, I know in Maryland, we have models where we call it itinerant, where you're kind of on call. You get a call, you go to a center, that's fine. And then depending on the jurisdictional model, some people have places where they're there, they're part of the staff. So they're there 1 day or 2 days a week, and they're regularly addressing things as they come up. And I think
the other thing you have to think about is just what capacity do you have right in the moment? If you have someone that's interested, how do you build something small and then work your way up to something bigger? Pennsylvania started with 3 consultants in one region of the state, and is now expanded across the state with 28 almost, and we're getting 2 more staff with rescue funds, so 30 people. So it was a process. And there was a lot of enhancements and evaluations and different things that were a part of that process to get where we are. So even if you just have a small capacity to do something, you should do something, and then build it as you get the resources and supporters.
Mm-hmm.
And I think I would just add to that, this is the #1 question that we get at the Center of Excellence. There is not one program we've provided technical assistance to that hasn't asked, what is the right way to do this? Are we doing this correctly? And it is, in my opinion, this is not a yes or no answer. This is a question of, so the way I answer that question is in that really annoying way of I answer it with a question. I say, what do you want to do? What are the goals of your program? What are your intended outcomes? Because there is a difference if you are very focused on that child-focused approach with reducing preschool expulsion. I mean, that's always kind of the overarching goal, but is there that? Are you really looking at climate, at overall climate, staff wellness? There are, and those are just 2 examples of many, many, many outcomes. So your mental health consultation implementation needs to be directly tied to what you hope to see as a result. So that's really what we spend the bulk of our time doing technical assistance on, is helping programs figure out what they want to do and how to get there.
Thank you. And I'll go ahead and allow Walter to give us our final comment about anything that you would like to address as we wrap up about equity.
Great. So thank you for saying anything that I'd like to address. And yet at the same time, I noticed that I'm given specific instructions in the chat as to exactly what I want to address. And it was all because I sent it to the panelists, but I actually intended to send it to all the attendees. So let me just read it out to you. And then if you want to ask any more questions following up, I'm sure anybody else in the group would be able to answer it. And that's, thanks for lifting up issues of equity. We are currently, and this is my team at Yale, we're currently looking at equity issues in access to mental health supports across a sample of about 60,000 childcare providers across the United States. There are lots of concerns regarding, who it is that has access and who it is that doesn't, and it's a complex thing, in order to look at. In addition to the issue of access across race and gender and rurality, please don't overlook equity issues across childcare setting, center-based versus home-based, or child age, preschoolers versus infants and toddlers, or the behavioral concern, externalizing, acting out concerns versus internalizing. being shy, withdrawn, and clingy, and things like that. In each of these three that I just mentioned, it is the latter that almost always gets the short end of what little supply of supports there are. And so race and gender absolutely are areas of equity concerns that we have, but those aren't really the only ones, unfortunately. We need to be looking across, a whole variety of different things. And with that having been said, there was one other thing that I'd love to take the liberty to mention, and that's a sincere thank you for Ashley Stowe and for Addie Eubanks, our ASL interpreters. While we were here talking with our mouths for a few minutes, Ashley and Addie were talking with their mouths and their hands for far, far longer. And so thank you for everything that you both were doing for us, sincerely.
Thank you to our outstanding presenters, Marco Candelaria, Walter Gilliam, Brandy Fox, Lana Naynide, and Lauren Rabinowitz for sharing their expertise and strategies with us today. And thank you to our interpreters, Ashley and Addie. And thanks to all of you for joining us for this segment of Training Institutes Live. We would appreciate you taking just a few moments to complete the evaluation for this workshop using the link that is posted in the chat. We take your feedback seriously, and it will help us to shape the upcoming series. As a reminder this summer, take us whenever and wherever you go. July and August workshops will be released the first week of each month and available to you all month long. Listen and learn to select workshops of your choosing or listen to them all. The link to the workshops on the website is posted in the chat. Again, thank you for joining us today, and we look forward to seeing you wherever you go in July and August.